welcome back guys. Now let's continue with the absorption of different substances and their sites, where different substances are absorbed in our GIT. Let's begin with the iron. Okay, iron, especially in Fe2 plus form. Fe2 plus form of iron is called as what? Ferrous. So this ferrous iron, where do you think it is absorbed? It is absorbed in duodenum. So in your duodenum, iron will be absorbed. Vitamin B9, also called as the folic acid, where you will absorb it? In jejunum. Okay, mainly in the jejunum. And vitamin B12, this is the most important point for the exam. Vitamin B12, which is also called as the cyanocobalamin, also the bile acids. Okay, vitamin B12 as well as bile acids, both of them, they will be absorbed in ileum. Okay, they will be absorbed in your ileum. But important point is, for vitamin B12 absorption, you need to have intrinsic factor. Vitamin B12, it's only absorbed in the presence of intrinsic factor. Whenever there is intrinsic factor, vitamin B12 is absorbed. Without intrinsic factor, vitamin B12 is not going to be absorbed. Okay, know that one point. So, how questions are going to show up in your exam? Let's say there is a parasite called as Diphyllobothrium latum. Okay, Diphyllobothrium latum, which is also called as a fish tape worm. Okay. Now, where is it going to live? Once you get this infection, this parasite is going to occupy your ileum. So, it is going to live in your ileum. As it is living in your ileum, tell me, it is going to interfere with the absorption of what? It will definitely interfere with the absorption of vitamin B12. So, this parasite causing the ileitis, so it is causing malabsorption of vitamin B12. So, right, Diphyllobothrium latum, which is a fish tape worm, it causes malabsorption of what? Vitamin B12, vitamin B12 malabsorption. So, leading to what? Anemia, Bothriocephalus anemia. So, why anemia? You all know, without vitamin B12, definitely there will be anemia. So, the anemia because of this parasite is called as the Bothriocephalus anemia. But you have to tell me, this Bothriocephalus anemia is nothing but the B12 deficiency anemia. So, it's a megaloblastic anemia. Megaloblastic type of anemia. Okay, megaloblastic anemia. Next guys, how question can come? Let's say the patient is having severe ileitis. Maybe because of Crohn's disease or ulcerative colitis, whatever might be the reason, the patient is having complete ileal resection, means completely we have removed the ileum. So, complete ileal resection, the patient will become deficient in vitamin B12. So, also remember complete ileal resection. This question was asked many times. Ileal resection means ileum removed. The patient will become vitamin B12 deficient, vitamin B12 deficient. Done. Next, let's see ankylostoma duodenale. See this ankylostoma duodenale, it's also a parasite. This guy, where he is living? He is living in the duodenum. In the name itself, it said it loves to live in the duodenum. When it is living in the duodenum, it interferes with what? Living in duodenum, it interferes with the absorption of iron. So, it will lead to iron malabsorption or iron deficiency. So, you tell me, whenever the patient is having iron deficiency, that can lead to again anemia. So, that is iron deficiency anemia, or you can say microcytic type of anemia. Iron deficiency causes microcytic anemia, and vitamin B9, B12 deficiency is going to cause megaloblastic anemia. Okay, so this is how you can expect a question. Very important thing is ileal resection. Upon doing ileal resection, the patient will become vitamin B12 deficient. Okay, leading to megaloblastic anemia. Next, how iron is going to be absorbed. Okay, very important. Guys, iron exists in two forms. There are two forms of iron. Let's say Fe2 plus form of iron, which is called as a ferrous form of iron. Fe3 plus form of iron is also called as a ferric. From where you will get the ferrous form of iron? You are going to get this ferrous form of iron from the animal sources. Ferric form of iron, you will get it from the plant sources. Okay. Now, Fe2 plus form of iron is absorbed. Okay, you can absorb Fe2 plus form of iron. But Fe3 plus form of iron in Fe3 plus form cannot be absorbed. It cannot be absorbed. So, tell me, the iron which is coming from the animal sources, it can be readily absorbed, but the iron which is coming from the plant sources, which is in Fe3 plus form, it cannot be absorbed. So, now let us see how iron is absorbing. We all know iron is absorbed in the duodenum. So, let us say here is the duodenum. Okay, here is the duodenum, guys. Now, today you have eaten some plant food. For example, you have taken something from food from the plant source. So what form of iron you are going to get? You are going to get Fe3 plus form of iron. Okay, you are going to get what form of iron, guys? Fe3 plus form of iron. Tell me, can you absorb it? No, you can't absorb it. But we are having a mechanism which can convert Fe3 plus form of iron to Fe2 plus form. No problem. Okay. Even for vegetarians, there is no problem because the Fe3 plus form of iron will be automatically converted to Fe2 plus form of iron with the help of a molecule called as duodenal cytochrome B. Very, very important. This duodenal cytochrome B, it converts the Fe3 plus form of iron back to the Fe2 plus form. Okay. So this duodenal cytochrome B, also called as ferrireductase. Ferrireductase. Done. Now, so we are having right now Fe2 plus form of iron which can be absorbed. Now this Fe2 plus form of iron, see, it is going into the duodenal epithelial cell. It is going in with the help of a transporter. Okay, with the help of a transporter called as DMT1. So with the help of this DMT1, the iron can be absorbed. The iron is absorbed into the cell. Now tell me, this Fe2 plus form of iron, yes, it came into the cell. Now where is it going? See, this Fe2 plus form of iron from the cell, it is coming out of the cell. It is coming out with the help of a different transporter called as a ferroportin 1. So tell me, guys, there are two transporters called as a DMT1, okay, divalent metal transporter 1, which is helping in the absorption of iron, and exit of iron with the help of a ferroportin 1. With the help of ferroportin 1, iron is coming out. Now tell me, where do you think this iron is going? So this iron is going into the blood. Now the iron is going into the blood, but you should never leave the iron alone. Okay, why? Because iron is a free radical, guys. Iron is a free radical. It generates with the help of the Fenton reaction. It creates the free radicals and it's going to cause a tissue damage. So first point number 1, we have to convert this Fe2 plus form of iron back to Fe3 plus form of iron. Okay, because Fe3 plus form of iron is the more stable form. It can be stored. So what we are doing? We are converting back the Fe2 plus form back to Fe3 plus form. Okay, back to Fe3 plus form with the help of a molecule called as a hephaestin. So see here, there is a molecule called as a hephaestin which is helping in the conversion of Fe2 plus back to Fe3 plus because Fe3 plus is more stable form. But problem with this Fe3 plus form of iron is it's a free radical. You should never keep it alone. So the iron, it is going to be bound with a plasma protein. So in the blood, within the blood, the iron is not in the free form. It is bound with a protein, plasma protein called as a transferrin. So in the plasma, there is a plasma protein called as a transferrin which is going to bind with the iron. Now see here in the name itself, it is there, transferrin. What it will do? It transports the iron to where? To the storage site. So now this transferrin is going to transfer the iron. See what it is doing? It is transporting the iron to the storage site, that is the liver. So in the liver, iron will be stored. In which form? In the liver, the iron is stored in Fe3 plus form. This iron which is stored in the liver, this is called as a ferritin. Ferritin. So now tell me, ferritin is which form of iron? Fe3 plus form of iron. Done. Now again repeating, iron, where is it absorbed? In your duodenum. In which form? Fe2 plus form. Who converts Fe3 plus form of iron to Fe2 plus form? Ferrireductase or duodenal cytochrome B. So once you have Fe2 plus form of iron, it is absorbed with the help of DMT1. Now the iron is coming out of the cell with the help of ferroportin 1. Now the Fe2 plus form is converted back to Fe3 plus form with the help of molecule called as hephaestin. Now this Fe3 plus form of iron in the blood, it is not alone. It is bound with transferrin. Transferrin transfers the iron to liver. So in the liver, iron is stored. That's a major site for the iron storage. My question to you now is, once you have sufficient amount of iron, means you are having sufficient amount of iron, satisfied or not satisfied? Do you want further iron absorption? No, because the further iron can lead to hemochromatosis. We all know iron overloaded state is called as a hemochromatosis. So once you have sufficient amount of iron in your liver, what liver is producing? Your liver is going to produce a molecule called as a hepcidin. Okay, your liver produces which molecule? Hepcidin, guys. Now what this hepcidin is doing? See, this hepcidin, it is coming and inhibiting the ferroportin. So this ferroportin, it is inhibited. Ferroportin is inhibited. So now tell me, iron absorption possible into the blood? Now do you think this iron will be absorbed into the blood? No, not possible. So what I am trying to say, this hepcidin is like giving a negative feedback. Enough amount of iron is already there in the body. So no need of further iron absorption. So this ferroportin is inhibited. So further iron absorption to the blood is not happening. So now tell me, where the iron is going to be stored now? So as the iron is not coming into the blood, so the iron will be locally stored in the cells. So the iron can be locally stored in the epithelial cells, that is called as a mucosal ferritin. Okay, mucosal ferritin. Okay, done. So with this, what we have completed, the iron absorption topic completed. Now, how the questions are going to come up in your exams? Okay, some questions see. What are the substances substances which increase iron absorption. Substances increasing the iron absorption. Guys, in the stomach itself, see, in the stomach, what do we have? Acid, or you can say HCl. Do you know what this acid will favor? The acid helps in the conversion of Fe3 plus form of iron to Fe2 plus form of iron. So acid, okay, acid or HCl, not only that, vitamin C. So these substances like acid and vitamin C, they helps in the conversion of Fe3 plus form of iron to Fe2 plus form of iron, and once you have Fe2 plus form of iron, it's going to be readily absorbed. Yes, acid increases iron absorption. Vitamin C or ascorbic acid, vitamin C increases the iron absorption. Then which substances decreases iron absorption? Okay, which substances decreases the iron absorption? See, just now I have taught you acid increases the iron absorption. Then what about the omeprazole, pantoprazole, antacids? Antacids decrease the acid. Without acid, iron absorption decreases. So listen, antacids. Okay, antacids decrease the iron absorption. Next, milk or any alkaline substances like milk, substances like tea, phytates, chemicals like phytates, tannates, okay, calcium, they all interfere with the iron absorption. Okay, they are all going to decrease the iron absorption. Recent question was tea. Tea decreases iron absorption. Why calcium decreases the iron absorption, guys? You have to know. First of all, tell me students, what is the name of this transporter that I am highlighting? DMT1, right? Divalent metal transporter. It's a divalent metal transporter like Fe2 plus, Ca2 plus, Mg2 plus. It's a divalent. It absorbs the divalent cations. Now, whenever there is calcium, okay, the calcium will compete for the transporter. The calcium will say, I want to go first. So, during that process, iron absorption will be stopped. So, calcium always compete with the iron, okay, during the absorption. So, whenever you are having the calcium supplements, okay, don't take the calcium supplements along with the iron supplements, because calcium will inhibit the iron absorption. Milk will inhibit the iron absorption because milk contains calcium. Okay, so these are the important substances which can decrease the iron absorption and can increase the iron absorption. Okay, next, what else you should know? Guys, some amount of iron, okay, some amount of iron is also going to your bone marrow. Okay, some iron is also going to your bone marrow. Why iron? Why the hell iron is going to bone marrow? Because in bone marrow there is hemoglobin production, okay, for HB, hemoglobin synthesis. So some amount of iron is also going to the bone marrow or erythroid marrow for the hemoglobin production. Okay, questions. Sir, we all know in the hemoglobin there is iron. Definitely in the center there is iron, sir. But iron is in which form? In hemoglobin. If they specifically ask you, what form of iron is stored in the liver? Fe3 plus, sir. But what form of iron is present in the hemoglobin? Your answer should be Fe2 plus only. The iron which is present in the hemoglobin is Fe2 plus. Okay, not Fe3 plus. But sometime, let's say because of some chemicals, poisons or free radical injury, some reason, if the iron which is present in the hemoglobin, if it is changing from Fe2 plus form to Fe3 plus form, tell me, is it good or bad? Definitely bad. That's a bad hemoglobin. So because of free radical injury, if Fe2 plus iron is converted into Fe3 plus form in the hemoglobin, so definitely that's a bad hemoglobin. So this hemoglobin is called as methemoglobin. Okay, methemoglobin. So now tell me, my dear students, methemoglobin means what? The iron is in Fe3 plus form. Okay, so that's what I am showing here. Normally the iron Fe2 plus form, if it is converting into Fe3 plus form, that is called as a methemoglobin. And why this happens? Because of the free radical injury or oxidative stress. Okay, but tell me, this methemoglobin, it's a bad hemoglobin, right? So what is the problem with this methemoglobin? Normally the hemoglobin binds with what? Oxygen. Do you think this methemoglobin, which is a bad hemoglobin, do you think it will bind with oxygen? No, it's not going to bind with the oxygen. So oxygen carrying capacity of the blood will be decreased. So leading to anemic type of hypoxia. Okay, it's going to cause anemic type of hypoxia. So the problem with methemoglobinemia is going to cause an anemic type of hypoxia. Okay, that is something bad. Next, in this absorption topic, what else you should know? Guys, again, I am discussing about the duodenum, same duodenum. Okay, here is a duodenum epithelial cell. This is the one duodenal epithelial cell, and here is a blood vessel, let's say. Now, see, duodenum is the most important site for the glucose absorption. See, most of the carbohydrates are absorbed in duodenum. So, what do we have? Carbohydrate called as a glucose. We are having glucose. Now, how you are going to absorb this glucose? Guys, glucose absorption always occurs along with the sodium. Okay, glucose is getting absorbed along with the sodium. So there is this one transporter which is absorbing the glucose but also absorbing the sodium. So two things are going together. So can I call it as a sodium glucose linked transporter? So what is the name of this transporter called as? SGLT type 1, sodium glucose linked transporter. Now I have explained you the basics. When two substances are going into the cell, okay, when two substances are going to the cell, we call it as a symport or transport, co-transport. All co-transporters are all symporters. They are example of which type of transport? They are all examples of secondary active transport. Without a doubt, secondary active transport. So now tell me, here the glucose is transported into the cell. Yes, with the help of glut, with the help of GLUT1, GLUT2, GLUT3. No, here gluts are not there. Here SGLTs are there. So here the glucose absorption is happening along with the sodium, which is an example of secondary active transport. Which is an example of secondary active transport. Okay, guys, glucose came into the cell. Now, do you want the glucose to be present in this GAT epithelial cells, duodenal epithelial cells, or do you want to send it into the blood? We have to send it to the blood. No, we have to absorb it into the blood. For that, there is a different transporter which is moving the glucose. Okay, which is moving the glucose into the blood. So what is the name of this transporter? This transporter is called as GLUT2. Okay, that's called as a GLUT2. So GLUT2, have I already explained you? All gluts are examples of these gluts, glucose transporters are examples of facilitated diffusion. What is the mnemonic I gave you? The mnemonic is like GF. All glucose transporters, all gluts are examples of facilitated diffusion. All co-transporters or symporters are examples of secondary active transport. So my dear students, tell me, the glucose absorption. Glucose absorption is an example of, first absorption to the cell is an example of secondary active transport, always occurs along with sodium. And the glucose absorption to the blood is an example of a facilitated diffusion with the help of GLUT2. Done. How the question is going to show up in your exam? On the luminal membrane, this is the lumen, no, here this is the lumen, all this area is the lumen. On the luminal membrane, which transporter is present? SGLT1. On the basolateral membrane, which transporter is present? GLUT2 is present. One is an example of secondary active transport, other is an example of facilitated diffusion. Done, fine. Then what about other molecules like fructose? See, fructose is very simple. See, fructose starts with which letter? F. Everything about fructose is F. It starts with F. Fructose transporter is GLUT5. GLUT5 with the help of GLUT5, F. So, fructose is getting absorbed into the cell with the help of which transporter? GLUT5. So, all gluts are example of what? Facilitated diffusion. So, fructose F, facilitated diffusion. And also, here also same thing. What is the transporter which is helping in the movement of fructose from the cell into the blood? Same, GLUT5, which is again example of facilitated diffusion. Okay. So fructose is very, very simple. Fructose entry into the cell, exit out of the cell, both are examples of GLUT5, both are examples of facilitated diffusion. But glucose is different. Glucose entry into the cell, SGLT1, exit out of the cell, GLUT2. Entry, secondary active transport, exit, facilitated diffusion. Done? You might be thinking, sir, how questions are going to show up in your exam? Okay. So question will be, why glucose is added to ORS solution? We all know ORS meaning oral rehydration solution or oral rehydration salts, which we will give in the condition of diarrhea, dehydration. In a patient who is getting dehydrated, we use the ORS solution. Now in this ORS, if you see the back side of the packet ORS, glucose will be there. Why we are adding glucose to the oral rehydration salts is simple, right? We can give sodium chloride. Why we are adding glucose? Because see, whenever there is glucose, whenever it is absorbing, it takes salts with it. Okay. So in order to absorb the glucose, you have to absorb the sodium. So glucose enhances the absorption of sodium. When the sodium is coming into the cell, water will follow the sodium. So always remember, glucose enhances the sodium absorption as well as water absorption, right? Why glucose is added to ORS? Because glucose increases sodium as well as water absorption. Okay, glucose facilitates the absorption of sodium as well as water. That is the reason. Look at here. Tell me whether these statements are true or false. Just check. Sir, glucose facilitates the absorption of sodium. True. Glucose absorption via help of SGLT1. Glucose in the intestines with the help of SGLT1. True. And always the SGLTs are examples of secondary active transport. Glucose absorption is an example of secondary active transport. True. But If someone asks you where is SGLT2 present, okay, we'll again discuss this in the renal physiology, but if someone asks you SGLT1 is present in the intestine, one for intestine, one similar to I, right? SGLT1 intestine, where is SGLT2 present? SGLT2 present is present in the PCT of the nephrons, proximal convoluted tubule of the nephrons. So SGLT2 is present in the kidneys, SGLT1 is present in the intestines. Okay, so with this we have successfully completed the topic of absorption of different substances. Also we have seen in detail about how iron is absorbed. Okay, what are the different steps, what are the conditions where iron absorption increases and the substances which decreases iron absorption, what is methemoglobinemia and how it is going to cause anemic hypoxia. Hope the video is helpful. Thank you.